Today, I'm going to discuss mucoepidermoid carcinoma, malignant neoplasm of salivary glands. Now, picture on the left swelling, ovoid, small in size, painless, and it is not invasive and generally not fixed. This picture, swelling, which is large in size, it is associated with symptoms, can cause neuralgia or can even cause hearing problems. It's comparatively large when compared to this swelling. Next, we have got a palatal swelling. It's on the lateral side of the palate. Again, the swelling is small. It's associated with symptoms. There can be dysphagia or masticatory or even breathing problem. The swelling is medium in size. Swelling on the extreme right, on the buccomandibular side, it's got a rapid growth. The symptoms are seen. It is an infiltrative lesion. It's continuously increasing in size and it is invasive. The common thing about all of these swellings is that they can have abrupt growth and they can cause fixation and invasion. So, till now we have seen that the clinical presentation is wide, age range in these patients also wide. Many such type of swelling are also seen in children, particularly second decade of life. Clinical behavior is wide. We don't know when these swellings will have sudden growth. They are seen in wide locations in any salivary gland tumor of the body. That means it can be seen major salivary gland or minor salivary gland. Clinically, the swellings which are small in size can resemble pleomorphic adenoma or Warthin's tumor, whereas the swellings which are very infiltrative can resemble metastatic tumors. So, in differential diagnosis, adenoid cystic carcinoma, various lymphomas, epithelial myoepithelial carcinoma, cystadenocarcinoma, clear cell carcinoma, or even metastatic lesions are considered. Now, all these swellings have some unique or characteristic histopathological findings, and hence the name is mucoepidermoid carcinoma. We have to remember their differential diagnosis, particularly seen in the region of parotid, pleomorphic adenoma, Warthin's tumor, or any cystic lesion, which I am repeating again. Here, in this case, the differential diagnosis can be any odontogenic tumor or bony lesion. This can be even fibrous dysplasia also or ossifying fibromas also, and in case of young child, that they can be juvenile ossifying fibromas also. Here, the differential diagnosis can be necrotizing cyalometaplasia, any odontogenic abscess. Here, the differential diagnosis, in addition to metastatic carcinoma, can be squamous cell carcinoma, other bony lesion, osteosarcoma. Now, what are the unique histopathological features which I have told you right now? Please remember, three types of cells are important for diagnosis of certain group of carcinomas which are called as mucoepidermoid carcinomas and which we are discussing. Number one, mucus cells. This picture we can see the mucus cells here. They are in the form of clusters of cells, or here they are sometimes singly or in groups of cells. The second group of cells is intermediate cells. The intermediate cells are smaller than mucus cells, but they have got a central nucleus and cytoplasm is pale. Third group of cells we will see in mucoepidermoid carcinomas are flat cells. The flat cells are again abundant proportions. They have got a nucleus and the cytoplasm is eosinophil. The number of cells can vary, and in addition to mucus cells, intermediate cells, and epidermoid cells, duct-like structures are also seen, and cellular atypia at cellular stage, at cell level, is variable among different tumors. Let us discuss these individual cells in detail. Number one, mucus cell. As I have already told you, they are in the form of clusters of cells. They are large and their nucleus is compressed towards one side. That means if this is the mucus cell, nucleus can be the one side of the cell. Generally, they have got clear cytoplasm and they can resemble clear cells. They are abundant in low grade mucoepidermoid carcinoma. The second group of cells which we are seeing here are intermediate cells. They are smaller than mucus cells, but we are seeing a distinct nucleus, central nucleus. It can be vesicular also, and cytoplasm is pale. The nucleus is in the center, and they are larger than epidermoid cells. The third group of cells is epidermoid cells. They are like any other cells of the body. For example, the cells in squamous cell carcinoma, they resemble the cells in squamous cell carcinoma. They are generally flat cells, squamous cells. They are smaller in size than mucous and intermediate cells. They have got a prominent nuclei, and these cells are arranged in bundles or groups of cells or islands of cells or even strands of cells. And mostly they are seen adjacent to large areas or hyalinized areas. So, on the basis of number of mucus cells, on the basis of cyst formation, and on the basis of atypia, these tumors are graded as low grade tumor, intermediate grade tumor, and high grade tumor. At this stage, we have to remember that low grade tumors have got good prognosis and high grade tumors have got bad prognosis. The grading is based on the amount of cyst formation. Number two, on the basis of cytologic atypia. Number three, relative number of mucus, epidermoid, and intermediate cells. That means all three components are important for the diagnosis of mucoepidermoid carcinoma, but at any stage of the tumor or in different tumors, these cells, the amount of cells can vary. Sometimes one component can dominate, or sometimes there is dominance of another component. Now, low grade mucoepidermoid carcinomas histopathologically have got large areas of cyst formation and number of mucus cells. If mucus cells dominate in any tumor, then these are low grade mucoepidermoid carcinoma. Generally, there is minimal or no cellular atypia, and there are no keratin pearls, or there are no hyalinized areas. In case of intermediate grade mucoepidermoid carcinomas, the picture is largely dominated by intermediate cell component. These intermediate cells have got a prominent nucleus. They are smaller than mucus cells. The cellular atypia may or may not be present, and they resemble more to squamous cells than to mucus cells. In case of high grade mucoepidermoid carcinoma, there are solid islands of squamous cells, which I have already told you. There is pleomorphism of cells, mitotic activity is more, and these resemble squamous cell carcinoma, and the prognosis is not good, it is bad. So, in addition to diversity in clinical features, behavior, age range, and location, we have seen the diversity histopathological features also. In 1945, Stewart and colleagues introduced this term mucoepidermoid to define a distinct salivary gland tumor consisting of mainly epidermoid and mucus producing cells. Number of these tumors have been studied as they are quite common. They are located in both major and minor salivary glands. So, multiple choice question point of view, these are located in both major and minor salivary glands. Major salivary glands, parotid gland is the location. Many of these are located in major salivary glands. Submandibular glands only 7%, whereas sublingual glands 3%. Mucoepidermoid carcinomas are seen. Among minor salivary glands, palate is the most common location. Then retromolar trigone, floor of the mouth, or other locations, and it is very rare in buccal mucosa. Particularly, when mucoepidermoid carcinomas are seen in lip, they resemble mucocele, particularly low grade, low grade mucoepidermoid carcinoma resemble mucocele. This is the other multi has been asked and has also been asked. Have to remember the pneumonia EP here. Important thing we again have to remember, it is most common salivary gland tumor, both adults and children. Here again, both, and it represents 10 to 15% of salivary gland neoplasm. The etiopathogenesis, that it arises from reserve cells, but not the reserve cells of intercalated duct cells than that in pleomorphic adenoma, but here they arise from reserve cells of excretory ducts. In case of pleomorphic adenoma, you have to remember there are interductal reserve cells. Here, in from the multiple choice question point of view, from the excretory ducts, mucoepidermoid carcinoma arises. Generally, the etiology is not known, but mucoepidermoid carcinoma are associated or more in patients under radiotherapy. Regarding the genetic features, most mucoepidermoid carcinoma harbor fusions involving MEML2 gene. Chromosomal translocations have been seen in chromosomes 11 and 19, resulting in MECT1 MAML2 fusion gene. MECT1 mucoepidermoid carcinoma gene and MALML2 gene. They can have a perineural spread like that seen in adenoid cystic carcinoma, and so careful and long-term follow-up is required. The ultrasound examination of mucoepidermoid carcinomas indicate a typical hypoechoic lesion with a partial or completely cystic appearance. We have to remember that normal parotid gland has hyperechoic lesion. CT findings, they are well circumscribed masses, usually with cystic components. But high grade tumors have poorly defined margins, they infiltrate locally, and they appear solid. The treatment is based on the grade. The low grade tumors have got wide local excision and no adjuvant therapy, radiotherapy is required. But high grade mucoepidermoid carcinomas, complete parotidectomy along with removal of facial nerve is required. For parotid tumors, again, neck dissection is advisable and adjuvant radiotherapy is required. If mucoepidermoid carcinoma is seen in submandibular or sublingual gland, generally whole of the submandibular and whole of sublingual gland is removed. Prognosis is good for low grade tumors. 95% or more chances of survival are there. For high grade tumors, the prognosis ranges from 30 to 54%, and there is high local recurrence rate, and so prognosis is bad. Coming to conclusion of mucoepidermoid carcinomas, there is variety not only in clinical presentation, behavior, and histopathological appearance, but they can vary location also. They have got wide age range, and all these factors, these diverse factors, have made these carcinomas challenging to stage and challenging for treatment. Thank you.